Hello everyone, welcome to the channel. My name is John Hardy. I'm a doctor of physical therapy. Today I'm going to go over how to examine the knee. Now this video is for educational purposes only. It's primarily made for healthcare professionals looking for a quick refresher on knee examination. Now this video won't be an exhaustive list of all the tests and measures, but we'll go over the basics for screening most common knee conditions. Now your subjective examination is going to be the most important tool to use because that's going to help you streamline your physical examination based on the patient's symptoms, their mechanism of injury, their aggravating factors, or their easing factors. And with that, let's get into physical examination. So first what you're going to do is you want to take a look at the patient's or client's standing posture. I like to start with the feet, working my way up, but you can also start from the trunk down. But basically when I'm looking at the feet there, I'm looking for, are they having excessive pronation or rolling in of their feet there, which can cause the knee to rotate inwards as well. Or if they have excessive supination, they're out on the outer edge of their feet. Also trying to look for, are they having any knee valgus? So if the knee just excessively turn inwards there or buckling inwards. I'll also check for, are they standing with the knees flexed more in a standing posture? So if the knee just bent forward or they're having difficulty with weight bearing or getting that knee fully extended. Also look up at their hips and their trunk, kind of see, are they favoring one side, putting weight on the right side versus their injured maybe left side. So I'm just kind of looking at their normal standing posture. Other thing we'll look at is squatting position. So one of the things I'll have you do is I'll have them face towards me, I'll have them squat down, and I want to take a look from the front and the side as they're squatting. This will give me a good indication, are they able to go through the full range of motion, are they having pain or weight shifting to one side. Also checking for any limitations in ankle range of motion, also hip range of motion as well, maybe something to consider. Other things we'll do is I'll take a look at their single leg standing balance there, seeing are they able to weight bear on their leg fully. So standing on one side, and then we would compare that to the opposite side as well. Other thing I'll also take a look at is a single leg squat or mini squat, basically having them stand on one leg, bend down, and I'm checking to see, are they having pain with this? Are they having any excessive knee valgus where their knee starts to rotate inwards with this? I'm checking for those as they go back and forth. I normally have them do about 3 repetitions or so if they're able to, and then compare it to the other side. Next what I'll have you do is I'll have them sit onto a table. And then based on this, you can do palpation here. I don't like to do palpation so much in a seated position. I primarily like to do it in a supine because I can do a lot of other tests and procedures while I'm there. But basically you would palpate around to the thigh muscles, working your way down to around the kneecap. It's a good place to kind of palpate for the knee joint line. So you would find these little soft pockets just below the kneecap. You go off to the outer edges and you should be able to sink your fingers into those little pockets. And this is going to be where the meniscus joint line is. So you'll be palpating along the edges around the joint line to check it for any sensitivity or tenderness. And then palpating along the center, checking for the patellar tendon, all the way to the tibial tubercle. And then checking for calf or posterior structures there. So also in this position, I like to do MMT or manual muscle testing. This is for testing for strength, seeing if they have any weakness or also if they have any strain. So generally you'll get pain elicited with muscle contractions. So I'll have them kick up their leg, go to the full range of motion. And then from this position, I'll have them bend the knee slightly, hold here, and then don't let me move them. I'll press down, again, looking for pain. Go ahead and relax. And then other times if they have pain, I'm checking, assessing where that pain location is. Is it around the kneecap? Is it into the thigh muscle? If it's up there into the thigh muscle, the muscle belly, I'm considering maybe possible muscle strain. If it's around the kneecap there, I want to do additional tests to kind of see what may be going on there. Other tests I will check is have them pull their leg back, checking for the hamstrings, having them pull back again. I'm assessing for posterior knee pain, also assessing for strength. Again, I would compare these on both sides to see if there is weakness left versus right. Next we'll do is we'll have them lying down in the supine position. So when the patient is lying down or in the supine position, one of the things you'll want to assess for, again, is palpation around the knee. Again, I like to palpate into the thigh, quadriceps muscle, working my way down into the knee, checking for the superior border of the kneecap or the patella, checking to see if there's any tenderness around the quadriceps tendon just above, working my way down around the edges of the patella, checking for, again, for pain, sensitivity, and then down into the inferior polar patella where the patellar tendon attaches. And I'll work my way down to the center and then down to the tibial tubercle. You can assess for the joint line in this position, but it's it's hard to find unless you're an experienced practitioner. So generally I don't like to palpate in this position. It's easier to find the joint line when the knee is flexed. But again, you can check for sensitivity along the medial part of the knee or the lateral part of the knee. And again, checking in the posterior region there. One thing you like to check for is sometimes if they have complaint of anterior knee pain is right on the inferior polar patella. We have a condition that's called jumper's knee when they have a tendinopathy going on. So you'll palpate here, and if they're having pain right on the inferior pole of the knee, one of the things you'll assess for, you would flex the knee and bend it. And if you palpate again, if that pain goes away, then generally that's the indication that they have a jumper's knee or a tendinosis or tendinopathy going on with a patellar tendon there. So next we want to do is evaluate the laxity of the knee. So you can do it in different positions. I'm going to evaluate the left knee here. So for assessing for ACL tears, there's 3 primary tests you want to do. One's going to be called the anterior drawer. This is where you lift up the leg. You put your fingers right underneath the hamstrings at the proximal tibia. So one of the things before we do the test, we want to make sure these hamstring muscles are relaxed. If they're tense and you're not sure, basically go ahead and have them pull their heel down into the table and trying to dig in. That should engage your hamstrings so you can feel, okay, those are tight. Then you want to have the patient to relax, make sure those hamstrings are nice and soft. And then what you're going to do is you're going to palpate around the called tibial plateaus or on each side of the tibial spine. And basically as your fingers are there into those grooves there, you're going to do a quick pull forward, assessing for laxity of the knee. And then also comparing it left versus right again, see if one's more lax versus the other. This test is not great for acute injuries if they injure their knee the same day or then the following day, maybe dealing with a lot of swelling, which may give you a false negative. Another test we like to do is called the Lockman test, where you can stabilize the femur, and then as long as their leg is not too girthy, you can use one hand here and one hand at the distal, or excuse me, proximal tibia. Again, stabilizing, and then you're going to pull forward on the tibia with their knee flexing approximately 20 to 30 degrees. One of the things I like to do to kind of help with if they have a girthy leg, I'll put my knee right underneath back of their thigh. I'll stabilize with my right hand, and then my left hand, I'm going to grab again that proximal tibia, and I'm going to do that same anterior shift forward and compare left versus right. The other test that's becoming more popular is called the lever test. This is the one where you're basically going to be putting your hand right underneath the calf. You're going to use your right hand on the distal femur, and you're going to apply a downward pressure. So as you're pressing down, a negative test is that their heel is going to pop up. A positive test is you posteriorly translate the femur downwards and the heel doesn't pop up and you can sense laxity. That's a positive test for a possible ACL tear. Again, that's called the lever test. It's more common and more popular as of recent literature. Other thing you're going to check for is the MCL. So the MCL, what you're going to do is basically you're going to first do what's called the valgus test, where you're going to basically put your hand at the knee joint line and you're going to be pushing inwards, trying to see if there's any laxity going on in the knee. Then you'll flex the knee approximately 20 degrees, apply that same valgus pressure, again to see if there's any pain or any laxity, and you compare left versus right. So next I'm going to do is the varus test. So this one, it's not commonly torn in the LCL ligament, but you can check it again, applying a medial pressure to the knee, then slightly flexing the knee, and then again applying that same medial pressure while you're stabilizing at the ankle. Other things you like to test for is the meniscus. So the meniscus, again, you can flex the knee, bring your thumbs into those pockets, and then you're going to be palpating around the knee joint line. So if they're having pain on the inside of the knee, or you're working your way out to the lateral side of the knee and they're having pain, that may be an indication that there's possibly a meniscus injury or cartilage injury. You want to make sure you palpate all the way to the back of the knee as well to kind of around the joint line to see and if they're having any pain in those areas there. One of the common tests we'll do is called the McMurray's test. This one's where you're going to fully flex the knee. You're going to externally rotate, so I'm trying to rotate the knee as much as I can using the ankle and the tibia. And then I'm going to extend the knee to see if that elicits or reproduces any pain. I can also apply a little bit of a valgus force and then extend the knee. Then to do the other side, I'm going to basically internally rotate the knee, put a little bit of varus force, and then fully extend the knee. Again, checking for pain around the joint line, any catching that's going on as well. That's the most common test for the meniscus. There's also a Thessaly's test there, but that one is not diagnostically accurate. Sometimes it just reproduces more pain for the patient, so I don't like to do it unless the patient's very non-irritable. Other things to check for is called patellofemoral syndrome, basically where you're trying to move the kneecap back and forth. Checking for pain around the kneecap. Again, you're palpating around the borders of the kneecap there to see if there's any pain or tenderness to that. You'll have them contract their muscle. You're trying to check for tracking of the kneecap, making sure it's tracking nice and straight in the groove. If you feel like it's laterally or medially shifting, or they're having any catching as they contract the knee there, that may be some patellar tracking issues. Also, we can do what's called a patellar grind test. I don't like to do patellar grind test, but essentially what you'll do is you'll palpate on here, have them contract the quad. If they have pain directly underneath the kneecap, then there's likely, again, some patellofemoral issues there. Another thing we also check for, again, checking the joint lines. A lot of times if the patient's over 55 years of age, they have some pain around the joint line. They complain of morning stiffness or stiffness with sitting from standing or prolonged inactivity, then we're considering, is there possible arthritic conditions going on there in the knee? Sometimes they'll have stiffness in general or lack of range of motion as far as fully bending or fully straightening. One of the things you're always trying to check for knee range of motion issues, making sure they got full extension of the knee without pain, and then if they can get full flexion of the knee. So one additional screening tool you want to consider is the Ottawa knee rules. So this is for patients that receive trauma to the knee and have one or more of the following: greater than 55 years of age, tenderness around the patella or kneecap, tenderness around the fibular head on the outside of the knee, or inability to weight bear at least 4 steps. So that's how you examine the knee for most common knee conditions. If you like this content, please like and subscribe. If you have any questions or suggestions, please leave them down in the comment section below. And with that, thank you, and I look forward to seeing you in the next video.